Hi, David.
Hi, Suniti. How are you? Hi, Jim.
Good.
Nick.
How are you?
Hi, everybody.
Morning.
Hello.
Hi, everybody. Welcome. As usual, we are in our matrix world. We're just allowing everybody to join. And once I've given everybody an opportunity to get in, and I'll keep admitting, I'll just kick things off and then hand over for the proceedings. All the usual rules apply. So remember to mute yourself. If you don't, I can find you. The microphone gives all away. So just in case you're thinking you can sneakily crunch those crisps in the background without turning your mute on, I will notice. So just be warned. Whilst we're waiting, I just want to say that Jim and David have this incredibly optimistic idea that they're going to do a presentation on, I don't even remember what, but just remember we will be post-election. So the idea that there's going to be lots of discussion about, what was it? I think security or something, I'm not sure. So I have a feeling we're going to have a lot to talk about, but maybe we won't know the result. Who knows? But
Okay.
all right. So I've given everybody, so we're about 1 minute in. I'll just keep admitting people. You don't need to worry about that. For those of you on the call, if you're not familiar with this, this is Health Tech Net, and this meeting is recorded. That includes the chat. So even if you send a private message to somebody, that chat does get recorded and stored. So be warned. Keep everything appropriate in terms of interactions. Please mute yourself. I ask that you control your own microphones. When we get to Q&A, we'll go through the usual process of trying to take questions. If you have the Q&A and you can use the chat, that's helpful. But you can also raise your hand and I'll call on you. Again, you control your own microphone just for simplicity's sake, but in terms of trying to coordinate, I'll do my best in terms of the sequencing of this. Otherwise, usual rules apply. So at this point, I'm just going to hand over to Jim. He's going to do the introductions and then we'll get kicking.
Okay, thank you. Well, good morning, everybody, or good afternoon. It's great to see you, and I'm looking forward to the presentation today. A particular appreciation to Ann Rosenblum, who sort of raised her hand and suggested that we get Joe Polini as a speaker for this session. So thanks for making that suggestion. And again to Suniti for arranging for Jen Bordenek to speak to us today. We're grateful to both of you. So there are going to be several things around today's specific presentation that I'm going to defer to Suniti to go through with, and I will turn that over to her in just a moment. I want to at least give you a highlight for next month's presentation. We're going to do the November meeting as a joint meeting with the Maryland chapter of HIMSS, and this will be a first for us, and we're pretty excited about that. We're going to do it on the topic of info blocking, which I know has been a really interesting. We've talked about it at several prior meetings, but we've never actually done a program on it. So I think this will be an interesting topic. The Maryland HIMSS chapter has already done a fair amount of work on it, preparation for it. We're going to be reaching out to see if we can find some help with moderating some of the topics. But is Genevieve Morris on the call yet?
Yep, I'm here, Jim.
Okay, I'd like to, for those of you who have been coming to meetings for a while, you may remember meeting Genevieve, who spoke to us back last fall, I think, which seems like about 20 years ago before COVID and all that. But Genevieve is sort of moderating the program from the HIMSS side. So let me ask you just to speak for a moment, Genevieve, about the plans for November, and then we'll turn it over to Suniti.
Yeah, so thank you, Jim, appreciate it. I co-chair the events work group for the Maryland
HIMSS board with Jennifer, who's also on. So for the information blocking event, the plan is for a 2-hour event, the first part of which will be some general overview and education from ONC folks who wrote the rule. And then the second half is going to be really a discussion group format, but broken up by type of actor. So the 3 main actors, as well as folks who are in that data seeker category. And we're hoping that it will be a nice roundtable discussion type thing where folks can share their questions and hopefully get some answers, and then share really how they're preparing to meet the requirements for info blocking, which we're all crossing our fingers gets delayed from November 2nd, though that rule hasn't released yet. So that'll be the format. We're hoping it'll be really interactive for folks. And as Jim mentioned, we are looking to Health Tech Net to provide a lawyer or 2 or other representative who's willing to be a discussion group leader, particularly for the data seeker category, or discussion group, I should say.
Genevieve, this is Jill DeGraff. I'm now with head of regulatory for Be Well Connected Health, and we are a data seeker. Data seeker. We've written comments to the OIG and others on some of the operational challenges that we experienced today, and would be happy to offer that feedback.
Excellent. I think Jill just volunteered to be a discussion group
That's
leader.
great.
So
Okay.
excellent. I have your contact info, so I will reach out to you about more details on it as we prep. Thank you.
All right, excellent. Thank you. Okay, well, we're looking forward to November. We think that'll be really interesting. So with that, let me turn it over to Suniti, who's going to talk about today's program.
Sure. David, do you have any other announcements before I?
Only one brief thing, and that is I'm aware that some of our members are receiving spam emails, or scam emails, I should say, in my name, but not from my email address. And I've talked to our, this has come up in the past, I've talked to our IT people about it. There's absolutely nothing I can do about it. People somehow, wherever they are, captured my name and are using it to send out emails. If you get any emails like that aren't from a Nelson Mullins address, they're spam, and don't open the attachment. If I could stop it, I would, but all I can do is warn everybody. It's not a hack. They did not get into our computer system, but maybe, I suppose it's possible they got into someone else's and saw my name, and that may be what happened. So apologies for that. Just a friendly warning about not opening up the attachment.
So I'm distressed to hear that. I just made a major investment in some property in London, David, that I thought you were selling for me. So I guess I'll have to do something about that.
Well, if you make any money on that, I am going to demand a piece.
Okay, we'll work that out.
Yeah,
Okay.
you know,
Thanks to everybody for continuing to participate virtually. You know, there's some of my clients and friends have actually said they think Zoom calls have benefits that in-person meetings don't, just in terms of being able to get people to participate, and in some ways the superior organization of these meetings. So it'll be wonderful when we can finally get back together personally again and actually have lunch together and that sort of thing. But in the meantime, I think this format has served us pretty well. Okay, Suniti, thank you for your leadership and along with Jim's and Ann's in putting this together, and we'll turn it over to you.
sure, thank you. And you know, as far as that email goes, I think that is happening not just on your email, David. It's happening more frequently now. I think the hacking activity has gone up in COVID for whatever reason, because of some of my other colleagues have mentioned that too. So, so today's topic, today's topic is about the intersection of public health and healthcare, which I have always felt that, and COVID-19 even brought to more, attention, is that we, just as in many other information, we live in information silos, because, there is public health information, there is healthcare information, but we don't talk to each other. I mean, public health, there was so much information, and, typically, historically, they've just calculated, counted, there's been immunization registry, birth defects, maybe cancer. Those have been kind of most commonly used registries at state level. But COVID-19 made us aware that there has to be more to it. And secondly, just when you have healthcare, as people are being treated for COVID-19, there is no information going back. Interestingly, when there was so much crisis in Italy, they said, all the pictures we saw from Italian hospitals, there wasn't a single picture where somebody was entering the information in a computer or somewhere. So all the knowledge that we might have gained there never is going to be transmitted. And that's probably happening in other places too. So a few months ago, we heard from a couple of HIEs about how they quickly came to occasion, created the, to repurpose their platform or made it available for all the stakeholders to share the information, come together, and so on. So I think today we will talk a little bit more. It's much more beyond HIE. One thought I had was, after 9/11, Department of Homeland Security was created. And one of the key issues behind that was what they learned during 9/11 is, emergency preparedness, hospitals, all the stakeholders, 911, there was no coordination. They never exchanged information. So all the information from one group to another didn't get transmitted. So it just makes me wonder that if we as a ecosystem and environment are going to learn from this and maybe create an information something, entity, whatever, that is going to bring all the different stakeholders somehow to share their information, like public health, like emergency management, like healthcare, labs, etc. Because as we've learned, some of the COVID-19 symptoms are all over, very different in different places. So having said that, we have a great program today. We're going to have Jennifer Kovic-Bordenick to begin the program. Then Dr. Farouk Alemi, I hope he joined. I didn't see him earlier. And then Joe Paulini. So Jen is the CEO of EHI, which many of you know. EHI is a leading organization. She's been doing this for 18 years. Jen, I didn't realize you've been doing this for this long, but it's great. So it's a great, she leads a team of experts that conduct research, education, advocacy across the spectrum of healthcare in all different topics. And I've been on many of their webinars, and they really provide awesome information to all of us. And she leads the development of national surveys and groundbreaking reports. So it's wonderful. Jen, it's nice to have you. Dr. Farouk Alemi is a faculty member at George Mason University. Sorry, Farouk.
The better university.
Right. Well, you were at Georgetown when I met you too. So you've been, Farouk has worked in both academia and health industry, so has a different and wonderful perspective about our healthcare system. And recently, Farouk, with his colleague at GMU, won a grant that addresses some of these issues. So Farouk is going to give us just a quick update on that. And then Joe Paulini, he's a CEO of Checks Out, which is a platform that was originally developed for something different, but he quickly pivoted to focus on contact tracing. And there are a few other people in our group that also, once the program is over, there are a few other people that have been doing some work in this space, so they would like to speak. So Tom Jackson and Jill are a couple of people that I would, once the program is over, we'll have them make some comments about that. So with that, Jen, I'm going to turn it over to you.
Thank you. And if I could just share my screen, that would be great. All right. Can everybody see that? All right, super. So I'm Jen Kovic-Bordenick. I'm the CEO of the eHealth Initiative and Foundation, and thanks for aging me, Suniti. Appreciate it. This is a really, I have to tell you, and Suniti asked me to talk a little bit about technology and what we're doing in the public health sector, and we've done a lot of work over the last 9 months that I'm going to share with you today. But I have to tell you personally, I have always been, and I know this is weird, I'm a sci-fi person. So I've always been addicted to those contagion movies, 28 days, zombie, Walking Dead, anything with a disease and a massive population I've been interested in. And I just always found it so fascinating, how they would go in and they would figure out what was wrong and discover the vaccine, et cetera. And then about 18 months ago, my husband was extremely ill and started with what we thought was salmonella and ended up in the hospital. I'll just tell you right now, he's fine, but ended up in the hospital for about 2 weeks and almost died. And I had my first real exchange with the infectious disease doctors, who I realized are my heroes and real detectives in this area. And also had my first experience with the actual public health sector. When my husband returned home from the hospital, we received a piece of paper from the state of Maryland about 2 or 3 weeks after he was home. Just a plain piece of paper with a table in it. And we were supposed to write in there where he'd been and what we thought are, where he might have gotten this infectious disease. And I thought, oh my gosh, this is such a joke. So when COVID-19 hit, and my first thought was, where are the contact tracers? Who's going to be able to figure this out? If we're relying upon those pieces of paper and these state health departments, we're in real trouble here. So that's a little bit of background in terms of where I'm coming from. I'm a huge fan of this area, but I'm also very familiar with the reality of it. So I'm going to talk a little bit today about some of the specific challenges around COVID-19, and then share with you some of the examples that we've found in the public sector that I think are really exciting. And then we're going to hear from other folks later today. Let me go on here. Real quick, for those of you who aren't familiar with eHealth Initiative, we're a nonprofit. We've been around for 20 years. And our current focus areas right now are consumer privacy, virtual care, analytics, SDOH, and of course, COVID-19 best practices. And we have been doing an enormous amount of programs over the last 9 months, educational programs, research, surveys around what's happening right now in the private sector to try to shine a light on it. We're a very small group of healthcare executives that come from across the spectrum of healthcare, payers, providers, researchers, academia, all really interested in figuring out how you use technology and innovation to improve care. Just as an example, in the last month, we released 2 reports, one looking at building a modern healthcare system and really federal policy recommendations from our COVID-19 federal policy work group. And then just this week, we released a really exciting report on SDOH specific to American Indian and Alaska Native communities and how they're combating COVID and some of the data issues around there. And I'm gonna mention that a little bit as we get through here. But we really have, I think, a lot of different access to different information and different organizations that may not be kind of the usual suspects that you think of. And the way that we get this information is through these executive roundtables. So this is how we do our work. We invite executives from across the country, large and small institutions, to join these roundtables. So we're not a big HIMSS organization with 20,000 people, but rather groups of 12, 15 people that gather together, as you can see here, an example, who talk about what's happening around the country in different places, very similar to this call today, and try to figure out what's working and if it is transferable to other organizations. So we spent a lot of time in the last 8 months trying to figure out how is data being used, and really trying to figure out why is this so hard. And I think the first thought with a lot of us in healthcare was, isn't this just like any other disease? Can't we just make a clinical pathway out of this and stick this into an EHR and be done with it? And this is a really different beast. And it's not easy to predict which cases are going to go south, and we don't have a lot of data on it right now. And I guess I wanted to share a little bit about why it's been so challenging to get innovation going in this area. First of all, and I don't know if all of you have seen this article. If you haven't, I would go back and read it in the New York Times, how data became one of the most powerful tools to fight a pandemic. And this was out in June, just a great article. We had a wonderful Sam Scarpino, I don't know if you guys know him, from Northeastern the Innovative Science Institute, and talked a little bit about this with us about a week or two ago in an executive roundtable. One of the issues with COVID is that, when this first happened, no single data repository of cases existed. Usually in healthcare, we go to AI and we go figure out where the data is and we, key into it. There was really no repository to go to here. And then the other problem, back to what I started with, the vast majority of all this public health data was collected on pen and paper. Sending these pieces of paper out to a family in Maryland, asking us to fill out a table, and that was how it was collected. So we were in a really different situation with this. So the whole idea of artificial intelligence and predictive modeling and forecasting, you can't do that when you don't have the data. The other thing about this is the timeline with COVID is just really difficult to track. And if you look at the public health data on this as well, I think a lot of you are probably familiar with this. If you look at the typical 30-day timeline for COVID resulting in death, and this is for cases that actually go south and result in death, it's really not until day 10 when somebody usually goes to the doctor. And by that point, it's too late. You've missed 10 days of data. So this isn't a disease that we can pull the data from early and figure out who's doing what. You've already missed a third of the data by the time you even know who the people are. So what this has really prompted is a lot of things going on in healthcare where people are trying to do kind of sentinel surveillance, I think, which is kind of early stage testing to try to go into populations and figure out who's at risk and test them and try to manage the outbreak. So to be able to really control COVID and interact with it effectively, you need to know where it is and you need to get ahead of it. And that's what we're really not doing a great job doing, and our innovation and technology isn't really getting ahead of it right now. So in terms of getting ahead of it, one thing I think COVID has showed us more than anything is that, it drives disparity. So these communities where COVID hits the most, it's really exposed, the striking, I guess, economic and healthcare inequities that are affecting African Americans, Latinx, Native people, underserved, vulnerable populations, immigrants, correctional facilities, nursing homes, homeless, disabled, all of those folks that are most vulnerable to COVID are also some of the folks we have the least quality data on. And this has made it extremely difficult because if you want to get ahead of people and test them, you have to be able to get to them. And we have not historically done a very good job of this. So I think the pandemic's made this really difficult. Another great article to look at is in the Journal of Public Health Management, the July-August issue, and talks about SDOH. Some really key factors there. We did a roundtable about a week or two ago on Native Americans. And I think, what one tribal leader said at that meeting was, this has really added stress to an already very stressed situation. So you're going into communities that already don't have water, may not have broadband, so we can't bring in our fancy telehealth apps and things because they don't necessarily work in those communities. You can't necessarily bring them to a homeless community. So a lot of the things that might work very well in a commercial population aren't going to work as well with some of these vulnerable communities. So it's really difficult to get ahead with. Okay, somebody needs to be muted. I don't have the control, Nick, so hopefully you can do it. Okay, and then finally, I think, this has been on everybody's mind, is healthcare really back in business? And this is where, I'm not sure, I'd be interested in your thoughts on this as well from the group. We keep seeing that, the stock market's doing great, oh, the economy's great, and then, it's not doing great. I saw this, I loved it, the trough of suck, which is pretty much where we are right now. You look at things like United Health Group, which is having this incredible quarterly profit, and you look at some of the health plans that are doing incredibly well. one thing I think is really interesting, you know, if you look at the hospital systems, people say, oh, they've posted great profits this year. Look at how well they're doing. If you peel back that a little bit and you look at it, the reason some of those groups are doing really well is because of their investment portfolios, not because of income that they're making from patients. And that's going to turn around. And a number of the providers that we talk to in our world are saying, you know, they're laying people off. So you're seeing that as well. You're seeing the layoffs, you're seeing the furloughs, you're seeing a shuffle of staff to different positions. So I think we are actually going to see that we're not quite back in business the way that we were before, but we're in a different type of business. So some of the tech companies I think are doing quite well. And initially, I think we saw a lot of the EHR companies didn't really have a huge impact economically from this. But unfortunately, we're hearing a lot about losses. And despite the fact, I think, you know, if you look at the numbers, there is a pickup of patients again. Patients are going back now to hospitals. They're getting procedures done now, but we're not seeing it. It's not going to make up for what we've lost. And we are still in a completely different market now if you look at care delivery. Because care delivery at this point is just really outside the box. You know, we all worried about telehealth and how is telehealth going to work? And are we going to be able to get doctors over the hump? And are they going to accept telehealth? You know, we can all agree, I think, that there were a ton of bumps getting telehealth going. But we are definitely over the hump right now. And we are living in this new world where care delivery, you know, we have basically stomped on the box and we are kind of living, you know, as we go, figuring this out, building the tracks, they say, as the train is running down them. And we've also seen the roles of a lot of these folks in care delivery changing. So the physician, you know, we've seen nurse practitioners really pick up the ball in a lot of cases, and the role of the pharmacist. You know, you're seeing CVS Pharmacy, Walgreens, is it Rite Aid this week just came out. We're seeing the pharmacist in these retail areas taking on a much broader role, almost as a caregiver. And this is really going to change care delivery. We are really outside of the four walls. And a lot of the technology that we're seeing right now is not about what's happening in the hospital. It's about what's happening in people's homes. And I think the technology has followed people home. And the more innovations that we see that follow people to home, I think are going to be the successful ones. And I think if this crisis has brought us anything, it's really helped expand healthcare beyond the hospital. Now, don't get me wrong. I mean, hospitals are still, you know, an incredible piece of the economy and critical importance. But we are seeing a whole new venue of care delivery, different sites, different locations, and we're seeing, you know, the patient really finally as kind of a location where care is delivered, and that's quite different. We're also seeing a real openness to technology that we haven't seen before. I mean, all those folks who are doing telehealth appointments that didn't want to, and you, yes, you are going to hear about, you know, my mother-in-law who really still wants to go into the doctor's office. But for the most part, you know, I can tell you as a parent, I think every parent loves not having to take off work and go to the pediatrician in the middle of the day. But being able to pull their kid in from the other room, stick them in front of the screen and talk to the doctor. We're seeing, you know, a real openness to technology and a different way to get care inside the patient's home in a much more convenient manner. I mean, I remember sitting on the phone waiting for the pediatrician to join, and I was annoyed that, you know, he was 5 minutes late. My gosh, I would have probably been sitting in his office for 45 minutes if this had been a year ago today. I think we're in a different place in terms of where the consumer is right now. And things have definitely shifted, which is nice. But it's a very, very different economy right now. And then finally, privacy. The eHealth Initiative, we run a grant for the Robert Wood Johnson Foundation on consumer health privacy. And prior to COVID, the discussion was very different. A lot of the same themes, I think, still emerge. People are still worried about their information getting out there. But COVID has educated people about their information. people now understand that there are groups out there that have a copy of whether or not I'm COVID positive or not. And people are also much more interested in understanding about the health status of those around them. You know, I want to know if my coworker that's sitting 5 feet away from me is positive. You know, is he contagious? Those are things, you know, maybe we hadn't thought about before. You know, you wouldn't want to know necessarily if your coworker was HIV positive, but now you definitely want to know if your coworker has COVID or has in the last, you know, 2 weeks. So I think there's a very different sense of what health information is and whether or not you want to keep it private and what you want to know about other people. So this is, again, changed the conversation in terms of privacy.
Jennifer?
Yeah.
David Main. I just have a quick question. I don't want to interrupt the flow.
No, it's a great
but
time.
back on telemedicine, are you seeing any difficulties in terms of reimbursement by insurance companies? I've heard that even though there were some changes early in the virus onset, that the insurance companies were more willing to reimburse physicians, for example, for a virtual appointment. I've also heard that increasingly, though, some of them are not willing to reimburse quite as much, and that's causing some waves. Are there trends there, or
yeah,
are you seeing anything in that realm?
Yeah, I think initially, you know, I would say for the first month or two, people weren't really sure. They didn't recognize that people were already getting reimbursed. Some of the commercial payers were actually much better at reimbursement initially, and they were reimbursing for telehealth already, and docs just didn't know it, but whether or not it was at the same rate. And then in April, when they came out with basically CMS that they were going to reimburse at the same rate as the in-office visits. And it took a while for that to kind of funnel down to the docs until they realized that that was the case. And then you're right, it was going to switch back. We were all worried it was going to switch back because they were going to end the emergency period, which they did not. But so there was a lot of concern about that ending. And now we did start to see, you know, last month with some of the commercial payers now saying, oh, well, maybe we're not going to pay quite as much for some of these telehealth visits. And they're getting a little bit, I would say they're thinking about it more. I think, I can't remember who mentioned this up front, David, if it was you or maybe Nick initially, but they're starting to think a little bit more about what does this mean? Should everybody get reimbursed at the same rate? If it's just kind of a quick follow-up visit, does that mean something different? So I think they are going to take a close look at that, and we are going to see that. And rightly so. I mean, is every telehealth appointment created equal? And does it take the same amount of labor that it does for the in-office visit? Maybe, maybe not. So I do think they're starting to look at that closely. So yeah, that's definitely.
Yeah. It could become a barrier to physicians' willingness to do virtual appointments if the reimbursement becomes a problem. So
it could. What I will say is we are seeing patients that are going to physicians who do telehealth because they don't want to go into the office. Because there's a lot of fear. So there is definitely movement of patients to some of those more convenient venues because they don't want to, you know, get up and they don't want to wait until a 9 to 11 and then 2 to 4 o'clock appointment on a Monday through Friday to get into the doctor. So we're seeing movement there as well. So yeah, I think it's definitely a shift.
Thank you.
Yeah. Did anybody else have any other questions while I'm just paused here?
Jen, this is Jill DeGraff. I have some questions that are, they tie a little bit back to one of your almost immediate slides about people now being able to go to the pharmacies and as well as the retail clinics and things like that. I'll just say anecdotally, consumers are also much more aware of reimbursement disparities for things like a diagnostic test, for things like a flu test, a flu shot vaccine. And those because as an example, you can go to the Walgreens pharmacist and you'll be charged differently than if you went into their retail clinic, which is insane. And so I think there's probably a good opportunity to do a little bit of investigation around those kind of kind of insane disparities.
Yeah,
Because consumers are intensely aware of it.
yeah.
Or become, you know, they're conditioned to become more aware of it because it's more front and center to get a flu shot, to, you know, where do I go to get a COVID test and how much is it going to cost me if it's not a public health laboratory?
That's right. And you see signs everywhere, you know, Harris Teeter, Walgreens, come in for your free flu shot. Is it really free, or are they charging your insurance company first? And then if they can't charge them, it's free. So, I mean, there's all of these little, I think that's a great point, Jill, a really great point. And I think consumers are becoming a lot smarter. And this has been an incredible education for them about healthcare information and about the options that they have. You know, people were kind of forced into, I don't know how many of you have gotten COVID tests yet, but getting a COVID test initially was very difficult. But now, you know, hopefully you're in locations where you can get a test more easily. So, but I think it's been an incredible education for consumers, and consumers are having to take on a lot more responsibility. And some, you know, the disparities are glaring right now. And I think that's been the biggest lesson learned, and the biggest, you know, shame really of our society, that we haven't taken care of, you know, large swaths of our communities. So anyway, let me go on. I'll get stuck on that. Okay, so one thing I want to do is talk about some of the different examples that we've seen. As I mentioned, we've done a ton of different roundtables, and I want to just highlight for you some of the companies and organizations and agencies that I think are doing some really cool things. And I'm just going to go through these very quickly. These have all come up in the last 3 weeks, really. So NVIDIA is working with NIH and basically figuring out how to scan through, I can't remember, it's, you know, something like 23 million lung scans, and figure out, you know, using AI techniques, which are those at greatest risk for going south, you know, through those lung scans. I mean, this is an incredible technology and innovation being used, you know, through the research of our NIH, National Institute of Health, and you know, would have never happened had it not been for COVID right now. But they have figured out how to do this. And this is going to be a tremendous asset, I think, for physicians across the country. The problem's going to be, you know, with a lot of these technologies is, how do we ingrain this? How do we scale some of these things? And how do we, you know, make them accessible for all different parts of the country? Another one that we heard about 2 weeks ago is Booz Allen, which is working with veterans, also working with FDA and a number of different agencies in the federal government right now. They've got this COVID simulator where they have basically figured out how to figure out when it's safe for employees to go back to work. And this is a great tool for large agencies to figure out, you know, based on infection rates, based on, this is very cool, GPS data, and where people are and where they are in the buildings and where they move, whether or not it's safe for them to go back to work, and actually rates them. It's almost like a traffic camera, you know, whether or not it's safe for your community to go back. And it gives you an actual date that it would be safe to return to work. And it's just really an incredible tool and an exciting thing. And I'm happy to like connect people if you want to learn more about some of these tools. Another one we've spent a lot of time on is Indian Health Services, who's doing just some really incredible work with tribes across the country. And I think a lot of you probably know, which you may not know, has, you know, the American Indian, Alaskan Native communities have been hit hardest. Even if you look at some of the numbers compared to Black Americans, it's an incredible amount that are basically not being counted. They do not have access to healthcare like other folks in the US have access to healthcare because of the way the policies are written and the sovereignty of the tribal nations. This is just a really tough challenge right now. And Indian Health Services actually as an agency has to work with tribes and try to get resources to these different locations, both urban and rural, which I never really thought about, but a lot of these tribes are actually in urban areas. So they've actually figured out how to use a lot of this data and scale on a very small scale specific communities that are at risk and being targeted, and just done incredible work. And Rear Admiral Wiaki and Rear Admiral Tote with Indian Health Services are just doing incredible work right now. And this is an agency, I would say, that's underfunded year after year after year. And it's really struggling right now, but they're doing great things with very little. Another group that's doing really cool stuff, Parkland Center for Clinical Innovation, is working within their community right now. And basically what they're doing right now is they've created kind of this proximity index to figure out who is most at risk, and then they text them and they bring them into the community system. Again, this is trying to get ahead of the curve and identify at-risk people before the spread happens, and to try to reduce hospital utilization. So looking at kind of their risk categories and lockdown issues, all of these things come into play in terms of how at risk the people in these communities are, and using the data to get ahead of these folks. And then this is really neat. I mean, I love CRISP. I think you guys have been reading about CRISP. Just a great group. And they have been part of this task force in Maryland, the Task Force on Vulnerable Populations for COVID-19, pulling out like the homeless population in Maryland. It's an incredible example of a private-public partnership model, working with all of these different groups here, sharing data. I mean, CRISP, I think, is one of the HIEs, and I don't know who spoke with your group a couple of weeks ago, but that's played a really significant key role in terms of sharing data about test results, sharing lab data, and making it much more accessible for people in the DC, Maryland, and Virginia area. And I think it's just a wonderful example of what an HIE could really be. So I can't say enough good things about this group. And then finally, I wanted to end with this example, because I think, you know, some of the things about this technology and some of the recommendations that are not working well is that we haven't really taken into consideration, particularly with these communities that are at risk, some of the cultural differences in terms of technology. Like technology can't be used and diagnosed, and people don't use technology in the same way, and that these cultural and ethnical differences really can impact how successful this technology and these innovations are. And one of the things I found just so fascinating, and you might have heard about this on in the news or read about it, but you know, if you look at the Navajo Nation and their adherence to wearing masks, the president of the Navajo Nation, President Nez, basically, and in all of the tribes, because of their culture, they have the great respect for their elders, and they wear their masks to protect their elders. And when the tribal leaders say, you know, wear your mask, because of the culture there, they had a significant decrease in case rates because they are so adherent to the mask wearing. So I think it's a great example of how some of these differences can actually play a positive part in resolving, you know, serving as a strategy for some of the COVID issues that we're dealing with right now. So just wanted to end with that example, which I think is great to have some good news. And there's my information right there. These are just a sampling of some of the companies that we've seen in the public sector and the private sector. As I mentioned, we are doing these programs a couple times a week. We are looking for as many examples of how technology and innovation can be used in COVID right now for public health, for hospitals, for patients, for consumers, and we are trying to figure out how do you scale it, and is it transferable? So I am open to any of you, if you'd like to contact me, if you've got a cool innovation or something that you think would be worthwhile sharing, please reach out to me and let me know, because that's what I'm living for right now, and trying to do as well as possible. So I will end there and hand it back to you, Suniti.
Okay, yeah, thank you, Jen, and we appreciate it. This was very helpful and very informative. Next, we have Farouk. Farouk, are you still on? So we wanted to give you, you wanted 5 minutes to kind of talk about the recent grant and what you're doing at GMU.
Sure, yes. Can I share a screen?
Yeah, Nick?
Yes, it's free to share.
Okay.
Meantime, Jen, thank you so much. That was a great presentation. Lots of information.
Yeah.
Thank you.
Great.
After those set of slides, I think you can see how not cool we are. But I just want to mention 3 things that we are doing that might be of use to some of you. We have recently received an NCI funded project to look at the COVID-19 and influenza differentiation, as well as we have finished a paper looking at the same issue across other countries where the data was available. Our project has 3 components. The first component is this issue of how do you differentiate flu from COVID, purely based on symptoms. And that component also includes a different definition of COVID than usually. COVID for us means not only respiratory COVID, but also gastrointestinal, neurological, inflammatory, and other types of COVID. The second component is a system that we have organized and licensed non-exclusively different organizations to carry out. 909 Healthcare is one of them. This system allows the monitoring of return to work based on scientific data on which symptoms are indicative of COVID. I encourage you to take a look at that surveillance system. And the third component is very exciting. You are all probably familiar with Bluetooth protocol, which allows 2 phones in their proximity to each other to be used to detect exposure. This is a different protocol. It's based on Wi-Fi, not on Bluetooth, so there's nothing to turn on. Most of our people who come to work and most of the people who come to school have their Bluetooth Wi-Fi on, so it's based on access points in enterprise Wi-Fi, and it's decentralized and it's passive, so there is no enrollment in the process. These are the 3 components of our project. We are very excited to share it with all of you. Suniti?
Suniti, this is Simon.
Yeah.
Can I just ask Farouk
Yeah,
a very quick
thanks.
question?
Yeah, go ahead, Simon.
Yeah, on that Wi-Fi one, is that based on Wi-Fi triangulation methods?
It is based on to some extent based on Wi-Fi triangulation. The Wi-Fi reports don't give the bars on your phone give a rough triangulation possibility, but it is mostly based on movement. So as you're walking in school or at work, we track your movement and we predict where you're going next. And if you go a certain pattern, we then identify where you might be. So it's a slightly different triangulation, but it does use triangulation on the bars of the Wi-Fi connection.
Cool, thank you.
Okay, thanks, Farouk, and we wish you all the best in this grant. So is this just started? You have, you're in the middle of the grant, Farouk?
This is expected to finish in 3 months.
Okay, great. So maybe in 3 months, you can come back and share the results.
Could you stop sharing for us, please? Thank you.
So we have our third and the last speaker now, Joe Polini. Joe, take it away.
I remember to unmute. Well, thank you so much. I appreciate it. Appreciate the opportunity to talk today. And I think I'll just start by telling you a little bit about the history of Checks Out and how we got going. And the story actually starts in China in 2009. I was on a consulting gig for a month, and my now co-founder, Jim Ivey, is on the line. He's going to kill me when I tell this story. Well, while I'm in China, he keeps emailing and calling me. He needed to talk. He had this great business idea, big business idea. He won't tell me over the phone. He was sure that the Chinese tapped the phones and tapped emails. So he was so excited. I just figured he had figured out how to turn lead into gold. So when I finally returned, and he woke me up the first morning back, serious jet lag. He says, "I got to tell you this story." He says, I was a month ago, I was in Baltimore, and after an ill-advised sleepover with a lady he'd never met, he realized he'd have to get tested. And, but he was railing, he hated the idea that he had to go back to the clinic and get his results. And why the hell don't they have electronic results notification? I got to wait for a letter to show up. And of course, I said, huh? He said, "Joe, sexually transmitted disease, STDs." And I was absolutely silent over that one. Now, Jim's a very persuasive guy, and a very short order, we're on a plane down to Atlanta to go to the STD annual CDC conference, prevention conference. And in the session after session, we start realizing that they're talking about their lack of any technology. Everything's done on paper, as Jen had mentioned, and this was a horribly underserved marketplace for infectious diseases, but in particular STDs. So we decided that there was an opportunity here, and a company was born. So Checks Out itself is actually a SaaS, and we primarily serve public health and infectious disease prevention and control. We work with state, territory, county, city, and local health departments from Hawaii to the U.S. Virgin Islands. And we help them streamline operations, maximize resources, and get patients into care fast. And that is a key metric to slowing the rates of infections and improving outcomes, is getting infected people into care fast and or isolation in the case of COVID. So what does STDs have to do with COVID and contact tracing? Well, when we first started, we provided STD clinics with patient notification, patient portals, some analytics, but we ended up over the years expanding our services to include case management and contact tracing, among other services. But the bottom line is that STDs, like COVID, infectious diseases, and to arrest the spread of infections, you have to contact trace. There's no other way of doing it. So over the years, we have been working with the CDC on developing our software, and they have used our software for studies. So when it became apparent that we were facing a pandemic, we reached out to the CDC, some of our contacts, and quickly found ourselves competing to become the CDC COVID response team's national contact tracing program. We ended up beating out over 40 companies, and were chosen to support 37 regional CDC teams that were set up to begin doing contact tracing pilots around the country. This was very exciting, and it was very exciting until they just suddenly killed the program. For unknown reasons, without any credible explanations, via email, I was informed that the CDC had killed the National Contact Tracing Program. And here we are, contact tracing is still working in fits and starts. And amazingly, we are still getting calls from counties and states about setting up programs for them. But that's that's a story for another time, preferably done over drinks. What it set checks out apart in the competition for the CDC program is our investigation and contact tracing capabilities. Contact tracing from the technology side is relatively new for public health in the way that Checks Out has actually developed it. Now, Jen had talked about paper, and believe it or not, we're still seeing a lot of paper. Obviously, there's been a lot of transition, but this is something that public health is just struggling with. Now, the difficulty and complexity of contact tracing, I thought I'd talk a little bit about one of our clients. The state of West Virginia is one of our clients, and they have an excellent COVID team. Certainly one of the best that we're aware of. They're very tight, very engaged, and very hardworking. And before the software, our software was even set up for them, they had recruited contact tracers from their entire public health system, and they installed epidemiologists from each of their 55 counties at the top line of their teams to oversee their programs. They also recruited about 500 in total university professors, students, and the National Guard to act as volunteer contact tracers. It was truly a marvelous all hands on deck execution here. So with all of these people and everything that they had to do through 55 counties, we had to train these 500 people, which is part of the complexity of any program being set up. Now, we did provide guides for the tracers, but we also did multiple online training sessions for the senior staff and then for the entire contact tracing team over the course of a couple of weeks. Our software was built with the healthcare workers in mind. So we made the software very easy to use, and most contact tracers were up and using the software after an hour of training. West Virginia also did something that was very smart, is they set up a Zoom command center 7 days a week to answer any questions users had in real time. And we also had people on those calls so that if there were any technical issues or concerns or questions, we would be there to answer them. We are also a preferred partner of Ring Central, which is an international VoIP company. So we were able to incorporate the ability for contact tracers to call people who tested positive right inside the software so they could work the investigation and talk to the patient. And all of this was all logged in real time as it was all going on. So if they clicked on something, everything was right there, and anybody could, with access to the system, could see what was going on with each and every contact tracer if there was an issue. We also, as we went along, had to set up isolation monitoring for patients so that they could give daily updates about their symptoms. So if patients were reporting declines in their health, the contact tracers could push them up through the system and help direct them into care. And then as we continued to develop, outbreak management became critical to managing these hotspots. So at this point, we're able to not only go into the school level or anywhere else for outbreaks, but in the case of schools, we're able to nail it down and drill right down to the classroom level as well. So that's kind of the setup for my talk here. And what I'd like to do is share a screen. Let me find my.
You want me to share it, Joe?
Yeah, actually, that'd be great. You're a little better at this. Why don't you go ahead? There it is. So our software is designed. Jim, we're going to skip all this other stuff, the scheduling, tracking patients. It's we have a very complicated and robust system here. But what any contact tracer can do is go in, they can look at their open investigations, and these come in through the labs. So we get lab reports multiple times during the day, and it will pull in all of the patients all of these people who tested positive, and then the system will sort out by county and direct individuals based on their location. We're here in the investigations, and Jim's going to open Taylor Swift, who has been reported as being a positive case. Now, when I mentioned earlier that we had designed this software for public health workers, we made this very, very simple. So that when they went in, if they needed to do an edit, they could just quickly go in and do an edit. If they make a change, it would automatically save the information. So nobody that's not using software all the time would be confused and forget to save information. We set the modules up here so that we could go step by step as they're doing their investigations, the questions that are required by the PUI, the patient under investigation, from the CDC and the individual state or county flavors. So they can go in and they can set up and log all the different information right there. It's automatically saved, and they can move through the modules one at a time. They can see what the condition is, the person, they can see their address information, they can see the outbreaks, and what we do is we also help them trace exactly where the outbreak happens. And as that's going on, we're building an automatic library so that nobody has to continue keying in information. So if it's a Gold's Gym in Charleston, they can very quickly find it. It's already in the, or if it's at a dorm, which may be more likely, you can find that information already in there. So we designed this so that people were able to work efficiently without having to worry about going and finding additional information. We have the communications module in here so that we can send texts, we can send emails automatically. So if we wanted to send a text, we would click into it. And we can have it send now. We have a template set up. They can put custom text messaging in there, and that automatically logs it into the system. And this goes for emails as well as phone calls. You see down in the lower right-hand corner, we have the Ring Central module, and they can call right through there, and it'll automatically log that information in for the individual while they're doing the communications. We can track signs and symptoms. So if the contact tracer gets a person on the phone, they can go in and add new symptoms, add information about the symptoms. If they're in isolation monitoring, you can actually go in there and get that information on the individual that you're tracking, so that if we see someone in serious decline, we're able to quickly go in there and get that information. There's all these modules like this one that collects information, all the questions that they want to know. Are you living in a multi-family home? Where were you? You know, are you a healthcare worker? Are you a food worker? So we went in and put in as much information as they wanted to collect, and that we were getting guidance from the CDC. Then we get down to the contact section, and this is where the rubber hits the road for contact tracers. Each one of these persons has been identified as a contact, and we're able to click into those and find that if we've been talking to them, if we've already talked to them in another investigation, we have that information in there already. We can also show a cluster diagram. And this cluster diagram, if you hover over an individual, you'll see it'll come up, it'll bring up a date of birth, it'll bring up what the condition is. You can see that one's COVID, and it also has a phone number in there. And the contact tracer would be able to click into that individual, so in this case, Dwayne Johnson, and also be able to make a call directly to Dwayne from this system, and it'll take the contact tracer into Dwayne's records and into Dwayne's investigation. And then we can trace, and you can continue tracing all of the people that are in this cluster that have been in contact. It's color coded. People in blue have not been tested yet. People in green have been tested and are negative. And people in red are the individuals who have actually tested positive. So we provide an environment that allows them to quickly work through each one of these contact tracing situations. And you got to understand, when we show this software to public health, they about fall over because a lot of this has been done in, they do it on pen and paper. The disease intervention specialists that are really the contact tracers out there, they have, they traditionally work out of notepads and then come back and rekey in information. This information this is also mobile optimized, so if they're working in tablets in the field, or if we have mobile testing mobile testing going on, they can run that all the way through the system from wherever they are, and it's all updated in real time. So it's bringing a level of real-time contact tracing into a situation where prior to this, it was if somebody lost their notepad or God forbid got hit by a bus and that pad got lost, all that information was gone. So that's the quick overview. Jim, what am I missing here? What have I missed?
The one thing that we didn't touch on is that we take all this information and we aggregate it. And we can aggregate this across different investigations, right? You might have different people in the state who don't have epi links to each other. However, they've all been at the same place, the same school, same place of work. So the software automatically aggregates that information and can alert supervisors, contact tracers of possible outbreaks. And in cases of where certain rules are in place, for instance, where you have a communal setting, we can automatically generate outbreaks and start bringing those people together so that we can then more effectively deploy resources and get to those people faster and get them into care. So you can see on our outbreaks page where all the outbreaks are listed, and we could do things like give you a heat map, and display that information any way that's best for your team. That was it.
Right.
Since I control things, I get to say this, but thanks to that, we've got a trending problem with Taylor Swift, Mark Wahlberg, Dwayne "The Rock" Johnson, who are all now suspected of having COVID-19. No, I'm kidding, of course.
Fantastic. Celebrity outbreak.
Yeah, great. Very good presentation. Are there any specific questions for Joe and his partner?
Can I call on Noam if you'd like to say it, or would you like me to ask the question?
Nick, I was thinking that if there are no specific ones, then maybe we'll give a few minutes to Tom and a few minutes to Jill to make comments on this overall topic, and then I'll turn it over to you to follow the Q&A.
Okay, absolutely.
All right, Tom, you're up.
Hi, how are you? Can everybody hear me okay?
Yep.
All right. For those of you who don't know me, my name is Tom Jackson. I'm president of Technology Solutions Group. And basically what we do, we create business solutions for niche applications within healthcare. A couple of examples, we came out with a hand hygiene monitoring tool using RFID a few years ago. We do surgical sponge tracking and OR management using RFID and 2D barcoding. So anyway, when this whole pandemic hit, we got the team together and we were looking for ways to actually help the cause. And what could we get into that would help, that we could actually deploy very, very quickly? And one of the biggest problems that we saw is hospitals and various healthcare organizations being able to procure masks and actually make sure that through the processes that they can be replaced very, very quickly. So those of you who are in healthcare know that you can go right now into like Costco and get just a regular mask, but based on the different layers, the cellulose contents, the elastomers, they're not really equipped to be within high-level healthcare environments such as surgery. So there's two mask types which are actually standards, 3M and Honeywell. And both of them are literally impossible to get these days. A lot of them are going into the supply chain focused on replenishing the government stockpile, and a lot of them are going overseas, mainly because they're getting a lot more money overseas than they are in this country. So it's a money and business driven cycle in regards to masks. So we thought, what can we do? And we've been decontaminating pharmacies and been setting up sterility protocols for years, basically making sure that the sterile areas conform to a lot of the protocols that should be set in place. Because right now, particulate can flow into sterile areas 3 different ways: through cross-contamination, in other words, touching something and then touching something in the sterile area, through the air, and through product actually going into the pharmacy itself. So we use a certain solution that has worked tremendously, and it doesn't deteriorate any of the products in pharma or in the compounding areas if you're doing institutional compounding pharmacies. We thought, why don't we migrate this over to mask decontamination? So typically what we had to do was, it was a 2-part solution. One is actually setting up the decontamination chambers. So everything can be done in a sterile area. We can actually do the packaging in a sterile area and get them back very, very quickly to the recipient. Okay, now I'll go through that in a minute. But believe it or not, the harder part of this was logistics. Because what CDC and OSHA and a lot of the governing agencies want is that mask going back to the original user. Okay, and the analogy I use, which is a little gross, but it's actually apropos, is it's kind of like wearing somebody else's underwear. Okay, you can put it in the washing machine and you can clean it, but do you really want to wear it? Okay, so what we've done is actually come up with a protocol to actually sterilize masks. And again, we've done a lot of the testing up to 20 times without any degrading of that particular mask. And we've actually done quite a bit of testing in regards to breakdown, cellulose content, elastomer mobility, whether it's going to break or not. So anyway, we are fairly conservative. We pretty much tell them at the 5th decontamination cycle, we're probably going to replace the mask for you. So let me take you through a typical scenario. Have a question? Oh, I'm sorry. Okay. Typically, we will set up the system within a hospital. Right now, we're in University of Maryland, and we have a printer and a touch screen. And we basically have set up a template on the touch screen that basically will ask you 5 different questions. Who the user is, you scan the employee ID, what the location is, how many masks you want, and where do you want them dispensed to, okay? Now, once that's done, basically that's recorded on the cloud, and we actually have a back-end database so you can actually access at what point your mask is at in decontamination and when it's actually going to be delivered back to you. We also generate a barcode label that those of you who have bought jewelry, you ever see the little barbell label on rings? Well, basically that's generated at the point of contact where you're generating all this information, and it's put around the elastomer of the mask, a very small label, linear barcode on it. So we use that as the tracking mechanism. So we're actually scanning that through the entire process and setting up validation points to let them know exactly where their mask is. Okay, now at the point the mask needs to be contaminated, we basically have what you might call a drop box all over the hospital. Okay, and we have it very clearly labeled with signs and on the box. It kind of looks like one of the recycle boxes where you throw your Coca-Cola can in. And all you do is you drop the mask in. And then we have facilities go around every couple of days, picking up all the red bags. And what they do, they send them back to us for decontamination. We actually log them into the system using barcode scanning. We log all that onto the cloud portal, and we go through a variety of different steps in regards to the decontamination process. Once decontamination is done, we actually put it in a sterile bag. We actually generate another label with the person's name, date it was decontaminated, and cycle count. Okay, so you know that this might have been the 2nd cycle, you got 3 more left. Okay, so with that being said, that's all delivered back to the hospital in alphabetical order. So it'll go to a pickup station. They can very easily dispense it. You just give your name, you scan your employee ID number, and you give them their mask back. Typically, we're turning these masks in about 1 day, plus whatever the freight time is going to be. So if it's local, normally the hospital will call us and we just basically pick them up, bring them to the decontamination chambers, and get them back, in some cases, same day. Okay, which means you're actually getting your mask quicker than actually ordering a mask. So, we've set up ROI models where literally you're saving about 70% of the cost of a new mask over a decontamination, over 5 decontamination cycles. So
I'm sorry, I thought you were done. Go ahead.
Okay. Well, anyway, I'm like about 10 seconds away. So anyway, what we've done, we've not only set up the ROI, to save a tremendous amount of cost, because we're doing this at a fraction of the cost of a new mask. But one of the things we didn't even anticipate is it's going to be so difficult to get 3M and Honeywell masks. That's the driving force behind this, because now you really take a lot of stress out of your life by having to find these through various suppliers and waiting for them to come in. So anyway, when we were talking, yeah, I know you wanted various ways that companies are helping the COVID process. And yeah, we're in about 4 different areas, but this is the one that seems to be the driving force that we've actually put out there.
Great.
So, yeah, if you talk about this, I mean, David's got all my contact information, and I'd be more than happy to talk to anybody who's interested.
And I think if you have some information which you provided, maybe we can, David, maybe we can put it on the website so for people to have access to it.
Of course, no problem.
Yeah. Okay. Thank you, Tom. That sounds really good.
Yeah. Thank you for having me.
Yeah. So Jill, good to see you after a long time. But I know you've been doing some work in this space, so maybe you can take a few minutes to kind of share with us. And
Sure. So I mentioned earlier that I recently joined Be Well Connected Health, but also I serve on the board of trustees for an organization called Connected DMV. And it's an organization that is really arranged around the fact that in the greater Washington, D.C. area, and we are Health Tech Net of Greater Washington, we are in fact 3 distinct jurisdictions with actually a total of something like 24 or 26 distinct government entities, as Ann Rosenblum really knows well. And when you have state and county and state level of governments and county, it makes it very challenging to coordinate at a regional level for our overall benefit. And nothing like COVID and contact tracing illustrates the challenges of that fragmentation and the need to come up with coordination and collaboration than this use case. And so one of the things that, and Connected DMV is a nonprofit, and it works specifically, this is just to provide some context, it works with existing regional organizations like the Greater Washington Board of Trade and the Metropolitan Washington Council on Governments and others, which have their own very established networks to build public and private sector partnership on key areas and initiatives. And one of the initiatives that we did try to push forward in the spring especially was a concept around coordinated contact tracing. And I can just tell you that, as we always know in technology, there are, in healthcare, great ideas and a business case in technology is usually, where those great ideas go to die. I mean, I'm being a little bit macabre about it, but we want technology to work, but just being able to work with, with what Joe was describing, what you're doing in West Virginia, the first question that came to mind for me is, well, how do those contacts, initial cases come into your flow? Sometimes they're going to come straight from a laboratory, and maybe they're going to come in through CRISP, which has got a direct link from those public, from some of the laboratories. But they might also need to come as known cases from our other jurisdictions, like the DC Health Department. How do those come into your system? And then subsequently, how do the close contacts that you've identified, if Jake Gyllenhaal actually lives in DC and not West Virginia, how do you send it over the transom? And without, these are logical business process issues that all of us would understand, and you think smart people can get behind it and make it solved. But the Metropolitan Washington Council on Government has convened a working group that started with epidemiologists from Virginia, Maryland, and DC. It expanded to include West Virginia. And, initial thoughts that this should be an easy problem because, of course, CRISP is supporting both DC and Maryland. And DC and Maryland both selected Salesforce as their contact tracing platform. But once you get beyond that, you start realizing so many infinite interoperability and business process challenges. Council, that working group is still at about week 22 of trying to get to a fully automated process to get the data to reliably cross over jurisdictional boundaries on a repeatable, frequent basis. So, I mean, that's the reality.
Yeah, Jim, you got a pretty good handle on this. Why don't you want to address some of this? And there was also a question about lab systems being notoriously bad when it comes to address and contact information and how we deal with that.
Yeah, let me just say, I know that a bunch of people on this call are anxious to ask some questions. So, I mean, maybe if some of the things, if you want to follow up, Joe and Jim, with Jill, I think you have everybody's contact information. And if we have time, we can come back. But I know there are questions are piling up in the chat box, and we want to make sure that we get through them too. So Jill, any last comment you want to make? And we'll move, I'll hand it over to Nick to follow, to run the Q&A.
Yeah, well, I mean, I think what we're finding as well, and I mean, I hadn't, no, I mean, I just want to get that point. I can go on with other things, but let's hear what others have to say.
Perfect. Thanks, Jill. Nick, you are in control.
Thank you very much. So we have a few questions that have come up in the chat box, and I want to be sure to give people the opportunity to ask them, and I will call on people that raise their hands as well. I'm going to go with the chat box first, and for those of you that put them in, I'm going to relate them as best as I can, and then if you want to jump in, please raise your hand so that I can see you and I'll take you. I do see one hand raised, just so that people are aware of that. So I'll take Jim's question first because it's directed to both of you. And I think important, especially in the contact tracing area, the issues of privacy and HIPAA implications from all of these tracking technologies and, you know, the tools that you talked about. Could you talk to that specifically and how you're approaching that and what the sort of solutions are relative to that?
Jim, you want to grab that?
Need to unmute. So when with COVID, we found that the mandate to protect the public health has really driven a lot of the ability for health departments to reach out to individuals and contact them. And when we do get a positive lab result, the health department will contact the patient and ask for their permission to enroll them in things like isolation monitoring. When somebody's been named as a contact, we just have to reach out to them. But everything is still protected with, you know, our HIPAA compliant servers and all the things that we generally do in healthcare to begin with. I'm going to just follow on, and I apologize. I know that's sort of my prerogative since I sort of sit in control of all of this. But my follow-up question to that is, I get all that, but it's the issue of people's concern or challenge with, wait a second, you've got all of this data. It's not so much the regulatory piece, it's how do you sort of generate enough sort of trust, as it were, within that. And I know that's very difficult, but any thoughts around that? Well, that's a good question. There's a difference between, say, a Bluetooth proximity alert application, like there's a lot of concern with like the ones that Apple and Google built, Virginia has COVID-wise, because there's a perception that your data may be shared. Wherein we're operating more like an electronic disease surveillance system that's just aggregating this information and making it available to public health officials. So we don't suffer as much of that as some of the applications do.
I wonder if I can add to that answer. We are looking at Wi-Fi proximity alerts, and right now we are in a research mode, so we get consent, but the objective is to have those alerts be passive, and you can opt out of these if you want to not have Wi-Fi access, which is quite unlikely because people need the Wi-Fi access at work. So yes, those issues are very important and
Okay.
very different.
Do you happen to know what an uptake is on people just voluntarily going with proximity tracing?
So the uptake for Bluetooth is in the 20s, 20 to 30%, but the uptake for Wi-Fi is not clear. So we will, that's purpose of our research.
Mm-hmm.
I want to be sure because we, given we've set this, we will run longer, and I'm not going to cut things short, but Noam, you asked a question with regards to the lab results, and you said you'd willing to jump in. So if you'd like to ask your question.
Sure. Can you hear me okay?
Yes.
I'm Art. I'm new to this group. I'm with a company called HTN Consulting. I spend all of my time with public health agencies working on things like electronic case reporting and immunization tracking, all that stuff. And I'm now shoulder deep in the CDC shit show over COVID response, which is a whole other topic perhaps. But it's just very focused on the contact tracing stuff. As I said in the chat, electronic lab results are notoriously bad when it comes to clear and correct and complete patient demographics, including especially contact information. I was just wondering, in general, what the contact tracing folks found when relying on those incoming messages as a starting point for contact tracing. Because if you can't find the infected person, because you can't figure out where the hell they live, you can't sort of do contact tracing about them. Thanks.
That's a great question. And there's a couple ways that we deal with that. Yeah, lab data is notoriously bad. One of the things that they'll do is the contact tracer will call the physician who ordered the test and try to get the information from the physician. That seems to be the best bet when the lab doesn't send over any contact info.
Okay, thank you. Richard, do you want to ask your question?
Can you hear me okay?
Yes, we can.
Wonderful. Well, first of all, thanks very much. It's a great presentation. This is Richard Singerman. The MIT Broad Initiative, it was just in the paper today in Wall Street Journal. It was in the paper a few weeks ago. They've come up with a way to do PCR testing for basically all the students, for all the schools in the Boston area, and then some even as far as Maine, at about $25 a test using things like just standard test tubes. They wrote their own software, and they can do a turnaround in now an average of 14 hours. And they're testing students roughly twice a week. My question probably for Jen is, you know, the standard test now is, the article says, about $100. So is there the potential to somehow make this program that's serving tens of thousands of students and allowing these universities to stay in business to scale to other parts of the country when MIT and Harvard at the Broad Institute have figured out a way to do things at about 25% on the dollar versus the commercial labs?
Sorry, who was your question to? Jim or Jen? Me?
I think, Jen, that was directed at you.
Oh, okay. I will try to answer that question. You know, I think the problem is because we're addressing this on a state-by-state scale. I think because you're doing something in Massachusetts or you're doing something in New York, it's not as easy to just, we didn't talk about the money issue so much, but this really, I think more than anything, is a money issue and a political issue. Can it be done? You know, yes. I mean, the answer is yes. If they're doing it there, they can do it here. It's just a matter of if there's the funding and the political will to do it here. And I don't know that there is.
Well, yeah, because it seems, I mean, I know there's a lot of talk about, you know, independent of what political side of the spectrum people are on,
yeah.
But, you know, centralization versus localization in the states. And this seems like a great example where if we left it up to a government grant funneled through CDC or NCI or whatever, or NIH, this might not happen in such an innovative, flexible way. And so there seems to be, even though it's more disaggregated at first, it seems like leveraging these innovation labs of the states is something very powerful we should keep on the radar.
I mean, I absolutely agree with you, and I think that it should be done, but should be done doesn't mean it's going to be done. And I think that there's so many examples of that, because when we look at the innovation that's occurring at so many different public health agencies across just the state of Maryland and then across the country, in different states, you know, it's tremendous. And the sharing, there isn't really a good national forum for, there isn't a good kind of test case, and there's no national structure set up to kind of share what's working in different parts of the country and then take it more broadly on a national approach. And I mean, that's kind of been the whole problem, I think, with this pandemic. So I think, you know, your question is spot on. And I think that goes kind of the heart of the issue in many ways.
All right, I don't see any other hands up, and I'm not seeing any. There was some additional follow-up discussion. I don't know if you saw that, Jim, Joe, on this issue of trust and so forth. You know, the compulsion, even with the localized technologies, and I guess also yourself, Farouk, because you jumped in, talking about the trust factor and how it was implemented in other countries. What I would say relative to that is that even in countries that have a very compliant and willing population, they still couldn't get the localized near-field communication tools, contact tracing apps in Singapore, for example, to much above 22, 23%. So, you know, there's still some trust challenges, but any additional thoughts around that from any of you?
I'm just curious, I guess, to Jim. I mean, do you think that it's going to get picked up? I mean, do you see this going up to 80%? I mean, what are your predictions in terms of how well it's be picked up? I mean, given what's happened to date in the US in terms of pickup on these?
Well, that's a great question. It's a question we couldn't answer, and it's why we never built a Bluetooth proximity app. Right, we stuck with conventional contact tracing, doing the stuff that we know that works, and we don't have those challenges.
Yeah. Does anybody think it's possible? I mean, yeah,
I'm going to say absolutely not. I don't think, from a technical standpoint, irrespective of, you know, the security and privacy, the challenge of differentiating people that are separated by walls, barriers, all of those other things, the lack of utility of those automated processes will preclude its widespread use because of all the false negatives. So, but you know, that's just me and my opinions. But
I think that the one advantage of Wi-Fi protocol is that it is decentralized and it's run by the employer, not by a central government or central organization or a public health department. The advantage of that is that some people will trust their school or their employer at a different level. And the other advantage of Wi-Fi protocol is that you can't live without it. And I don't see how people would exist without Wi-Fi. So they are passively part of it.
It sits on the Maslow's hierarchy these days, I think. And I am aware, at least one of my clients is using Wi-Fi technology to find students that are aggregating in larger numbers than they allow, and then going and doing actual in-person enforcement to break up those groups. Jim.
So, okay, I'm unmuted. I'm sure somebody in this group is going to know the answer to this, but I'm suspecting that contact tracing is a situation where we can allow the perfect to be the enemy of the good. And I don't know, I mean, I'm sure we can all think up 100 reasons that the best contact tracing system on the planet isn't going to pick up everybody's path and everybody's contact. But how good does it have to be worth pursuing? I hope that question makes sense.
Mm-hmm. Yeah.
Can I respond to that?
Sure.
One of the things that we try to think about, and I think it sort of should speak to common sense, is that any iterative advancement should contribute to overall reducing the rate of transmission, the R naught. And and our ability to do that depends on having a robust public health infrastructure for reporting, aggregating and reporting, not just at a local state level, but regional and national. And you know, I think that we probably all, I mean, that's actually ends up being the challenge. Like there can be all sorts of great innovations, laboratories of innovation, but we should be able to, you know, measure their impact across that baseline. And if we don't even have that simple measure to evaluate these solutions, which is unfortunate.
So one of the things that the public health department in Virginia, for example, has done is has required every employer more than 50 employees to do their own contact tracing. So that's the public health's requirement of the employers, which makes many employers did not know how to do contact tracing. Mm-hmm. And they are pushed into this environment to accomplish this, and they are not doing a great job of it. So if we can develop tools to actually assist them, de facto, we are assisting public health departments.
One of the other things is that, you know, none of this is static. Like back in April is when Apple and Google announced their exposure notification framework. And then they first, I guess maybe a month later, said that they were going to provide conditions of use for public health authorities to authorize an app for their specific jurisdictions. And then in September, they said, we're not going to prevent you from building your own app, but we can now enable those exposure notifications automatically for anyone who's on a Google or Apple phone. And so what I haven't seen is any subsequent reporting about whether or not public health authorities in any jurisdictions are actually taking advantage of that Apple and Google framework and whether it's being implemented into their contact tracing operations. I'm wondering if anyone has followed that.
I don't have a special contact, but I do have a doctoral student who works with the public health department in their contact tracing. And from her report, it's clear that they are not in any way using technology. They should be using the technology that is described in this talk. They are not using it, at least in the ones that we have contact with. And they definitely are not using Bluetooth contact or any automated contact tracing. George Mason University itself is not using our work. So it's an amazing situation.
Yeah, well, and I mean, the 22 weeks it's taken just to send secure FTP CSV files on some kind of regular basis between Northern Virginia, DC, and Maryland is kind of an illustration of how
it's amazing.
The process interoperability is incredibly challenging.
Very challenging, and the real issue.
Yeah.
So we've tried to keep these meetings below the original in part. I've got one other question. Unless there are other questions, I'm just going to ask Lloyd to ask his question, then we'll close out. Lloyd, if you want to go. Need to unmute.
Yep. Hey, I'm no longer muted. One of the things I'm aware of is different here than from, say, Korea, is a promotion of, let's just call it proximity awareness. Because like, unless you happen to go to the Virginia Department of Health website where you can look up how many cases there are in your zip code, you're not really likely to know what the odds are that you live someplace where there are a bunch of people who are infected. And it's my instinct, just from behavioral economics, that that's part of the reason why Americans tend to be fairly cavalier about this. And that's as opposed to, say, South Korea, where they not only, the government not only looks at people's cell phone data, but they actually send you SMS messages if your phone was close to a phone of somebody known to be infected, which kind of implies that you are. And I'm sensing that, you know, and particularly since the president doesn't really seem to want to promote a general sense of caution among the populace, that that's part of the problem, just that you're not actually communicating out to the public the amount of incidence information you already have.
I don't know if anybody wants to take that. I will say that I put in the chat, there is a local culling of data that provides local resource and risk assessment based down to the county level from Brown University. I put the link in the chat box if anybody's interested. Any of our speakers want to take that on? Otherwise, I'm going to hand it over to Jim and allow him to thank our speakers and so forth. I take silence as agreement. That's always the fastest and rapidest move to get consensus on any Zoom meeting, especially if you can mute everybody, which is one of the things I can do, but I haven't done that.
Okay.
So I'm going to say thank you to our presenters. Great content. Really enjoyed it. I'm going to hand over to Jim. He'll do the formal close.
Okay. Well, Nick, thank you very much for moderating. Again, thanks to Jen, to Joe Polini, and to Dr. Alimi for your participation, and of course to Jill and Tom Jackson as well. Really interesting session. I feel like I've learned a lot, and I've got a lot of homework to do. So we will look forward to seeing you in November for our joint meeting with HIMSS on data blocking. So have a good rest of the day, everybody. Thank you.
Enjoy the election in the meantime.
Right. Right.
Vote.
All right, thanks everybody. That's the end of the formal presentation. Appreciate the presenters. This is Health Tech Net presentation for October the 16th. Thanks. Bye-bye.